Saturday, March 27 is the Worldwide Endo March, a campaign aimed at raising awareness of endometriosis, a disease that affects 1 in 9 women and those who identify as gender diverse. That's approximately 200 million worldwide. The campaign and its events are all run by volunteers who are passionate about creating change for those with endometriosis, to raise funds, increase education and raise awareness. In previous years, on this day, we have hosted educational high tea fundraising events across the country. This year, it's gone virtual with this Symposium, Endometriosis, In Conversation and Consultation. My name is Ellie Angel-Mobbs and I'm a radio announcer at 104.1 Today FM in Sydney and host of the Endometriosis Australia podcast. Today, it is an honour to be joined by some of our Endo Warriors sharing their experiences and advice. Holly Crawford is a retired Australian snowboard halfpipe athlete who competed internationally between 2002 to 2018. She's a 4-time Winter Olympian, the 2011 halfpipe world champion and claimed 4 World Cup wins alongside 16 other World Cup and World Championship medals. It's an impressive resume. Donna Ciccia is the co-founder and director of Endometriosis Australia. Thank you, Donna, today for your time because you are so busy. Hoda Hannaway is a Sydney-based cooking enthusiast, media personality and ex-MasterChef Australia contestant. She has 3 gorgeous children, Hassan, Mariam and Maya, all of whom are her biggest fans. Hoda, Donna, Holly, thank you so much for your time today on what is a special day, March 27, the Endo Worldwide March. How are you feeling at the moment?
Really good, actually.
No one's in any pain? It's always, when I have these chats with other Endo Warriors, I always just want to make sure we're feeling good, we're feeling happy, and we're here and we're going to be really open and honest with this conversation today. Hoda, I want to start with you.
Yeah, sure.
When did you first discover the word endometriosis?
I'm going to say it was when I was 19 years old, when I finally had enough of experiencing so much pain for about 7 years prior to that. And I decided to, do a bit of research about what's happening to my body, why am I experiencing so much pain, and along with that, other symptoms. And that's when I discovered the word endometriosis and proceeded to start my journey on getting a diagnosis.
Let me guess, the doctor dropped the E word and you went, I have no idea what that is. This could be some sort of prehistoric dinosaur from the olden ages, because it is a foreign word for so many people. You probably walked out at that moment going, okay, what have I stumbled into? And then you just discover this whole new world.
My story is slightly different. I went to a GP first, and GP sent me to a gynecologist. That first gynae, I was not really impressed with how I was treated, and also felt like I wasn't heard. So what I did do after that was I went home and I started to research myself. Disclaimer, I know how to filter through Google.
Dr. Google.
I don't recommend that for anyone, but it's really, I do know how to filter through that. And, for me, I came up with 2 options. That's how I stumbled across endometriosis. And for me, my symptoms were either that or polycystic ovaries. And so what I did then was research a gynecologist who specialised in either or. And I emailed that gynae with my whole life history and what I think I have, and the rest is history. Wow. I did have endometriosis.
You're right.
So that's how I got my diagnosis. We're talking about in 2008. Earlier than that, 2005. So back then, we're talking now that there's not a lot of research, but back then it was almost unheard of. And that's why I think I had a bit of difficulty with diagnosis.
We'll talk a little bit more about research and funding later on in this chat, but I wanted to chat with Holly, who is a former Winter Olympian. You've competed the highest level in your sport, the half-pipe snowboarding. As an athlete, dealing with endometriosis, like physically, that must have just been so hard for you.
I actually wasn't diagnosed until 2019 after I retired. I'm no stranger to pain. I spent a large part of my career broken but still competing. So, I mean, in that respect, I think it shadowed the endometriosis a little. You know, when you've got a bone sticking out of your arm or you've just attempted to break your neck, you're not really thinking about those sorts of things. No, but once I retired and slowed down a little, I ended up in paroxysms of pain and being no stranger to it, you know, thought, goodness, you know, what is this? So I was a bit, you know, I didn't do my own research. I went to the doctor and thankfully it was 2018, not 2008. And my GP suspected that it was endo. So in that respect, I was pretty lucky.
Wow. The fact that you didn't, you know, realise while you were overseas competing that your body was doing this to you.
I mean, there were many...
As you said, you had so much focus on all these other injuries.
Yeah, there were many times, you know, and there's a lot of signs, you know, when I broke my pelvis and any number of other things, and times when it affected my training, you know, and I wasn't really, you know, you kind of get on with it after a point. You know, if you've got a few fractured ribs and you're trying to drop into a 22-foot half pipe, there's some other things you're not really thinking about too much.
Just sounds so cool. Just dropping into my half pipe. Yeah. I play songs on the radio. Now, Donna, you are the co-founder of Endometriosis Australia. You're like the mother hen. You've helped to make all of this happen.
A bit of an endo mama.
You are the endo mum, especially to me. Now, when were you first introduced to endo?
I was actually at a barbecue with friends and it was suggested that that could be what was going on for me. And I was in my late 20s, early 30s. So that was when I first heard the word, really. I have an aunt through marriage who has been supportive educationally for me when I was a lot younger, saying this is what you've got, but I really didn't know what it was. So I wasn't diagnosed until I was 31.
You're lucky to have gone to that barbecue and to have a friendship group around you being able to have that conversation, because I know for me, going through the pain when I was young, and I was extremely lucky that my mum is a retired nurse and she had endometriosis, so did her two sisters. So we were familiar with the language of endo, and I'd been introduced to that when I was 15 and I first started having the heavy periods. But then trying to tell a 15-year-old girl, your best friend at school, I've got painful periods and it could be this, but I don't know whether or not it's this because it's this invisible disease. And just to have a chat around periods with your friends, well, that's a taboo topic, especially going back, 20 years ago when I was at school. How did you, Hoda, have that conversation with your friends, close friends, that, hey, I've got this going on and I might not be able to attend events?
It was really hard growing up. I'm going to take myself back because by you saying that, school triggered me a bit, because it was at school when the most embarrassing moments would occur with it, and because I had heavy periods as well. And often I would leak at school and it would be like so embarrassing.
It's every girl's nightmare.
It is, oh yeah. So that didn't have happy memories, but I think it made the conversation easier to have with my friends because they witnessed it and then they tried to protect me as well every time something like that happened. So for me, growing up, it is taboo. Talking about anything to do with the reproductive system of a female is taboo. We don't usually talk about periods, bleeding, pain and whatnot. But, I've always been a outspoken person.
That's why we love you at Endometriosis Australia, because we need to be having these conversations and opening up. And for you as well, with your background and your culture, it would be a difficult conversation to open up with.
Yeah, look, I've always gone against the grain, and I started with my mum. So with mum used to tell me, we can use language, right? Mum used to tell me, oh, I'll use the right language, be quiet and go away, because like that, it was normal, you know. And that was just their level, that was their experience of periods to begin with, was that, look, everyone goes through pains, you know, and I was like, no, this is not normal. And so then I just embarked, I go, right, that's it. I just stood it. I remember that day actually quite clearly. She was in the kitchen cooking, ironically, and I stood there in a lot of pain going, this is not normal. I'm going to research it and I'm going to see what's going on. She just turned around and went, you know what? Good luck with that, and let me be on my merry way. But that's, you know, it's no wonder. A lot of the times it's not spoken about. Painful periods or heavy periods is just considered a normal thing, and no one really has looked into it. So here I am, and speaking about it.
You've been on a cooking show. Yeah. That moment where your mum just told you to be quiet. You were on MasterChef and you've been doing some amazing work with cooking shows. In the community as well for you, have you seen any big issues around endometriosis and girls who are struggling through it, not being able to have a conversation?
Look, I'm seeing it more so now being like a media personality. When I'm sort of posting about endometriosis, and I tend to post not just information that's available, I post my personal stuff. So when I'm in pain, I'll post something about being in pain, you know, and a lot of, I've had quite a few women from the same culture reach out and say, oh, thank goodness someone's speaking about it, because, you know, I think it's more prevalent than we know of, and the more education people are receiving, the more they're actually knowing sort of what to pinpoint when they go and see the GP. And that's sort of, I look at myself as just, you know, that gateway between that individual who is used to having everything swept under the carpet and getting a diagnosis, or at least just, you know, trying to find out what's going on for them. Yeah. Because, you know, no one wants to be in pain 24/7.
No. It's not
I
a fun
certainly
time.
did not. It's
Holly will probably speak quite highly
it's
about
not a good idea.
So Holly, as someone who's represented our country at an elite level, going to Olympics, being in all these foreign countries and living an amazing life, you've now spoken about your journey with endometriosis and that you've had it. You were diagnosed a couple of years ago now. Have you had other athletes come to you and say, hey, I'm kind of showing similar symptoms to what could link to endometriosis? Have you noticed that that's popping up now?
Even at the time when I wasn't aware, I had other athletes, you know, sort of ask and just say, you know, when you get your period, you know, and I'd say, yeah, it really, really hurts. And they say, yeah, does your back get really sore? I say, yeah, it does. They say, what do? I say, you just get on with it, you know, because that's what we do. That's what you do, right? You just get on with it. And there was no one there, you know, giving me this information, you know, there was no pathway to sort of go down. You know, a lot, I mean, they're finding a lot that even with women in sport, even the topic of periods is not, you know, something that they've discussed a lot, you know, with physios or doctors, you know, so it's something that you just didn't really discuss. So we'd discuss it amongst ourselves, sort of, but you don't really go to your doctor or your physio and say, you know, my back's really sore, I think it's my period, when, you know, you've got a bone sticking out of your arm. It's not really a thing.
Yeah, it's not really the number one priority for you. You're trying to sort out just quickly, how many broken bones have you had?
Most of the bones in my body
Okay.
Have been broken at one time or another.
And period, the endometriosis pain is up there with the broken bones?
Most definitely, yeah. And I mean, even, you know, some of the bones that I have broken, you know, my pelvis and any number of other pains, you know, looking back, likely are actually related to the endo.
Wow.
Yeah.
How are you feeling at the moment?
Much better. I actually, after my surgery, I felt 100% better for a time, and, you know, felt like I could have, you know, run a marathon, no trouble at all, and sort of wanted my entire sporting career all over again without, you know, without the extra pain of the endo, or at least, you know, knowing what to do about it.
Do you think you could have been more successful if you had known about endometriosis at a young age?
I mean, it's possible. Anything's possible.
Absolutely. Well, someone who is very vocal in Australia about raising awareness for endometriosis is our director, the co-founder, Donna. You created this amazing charity. What made you go, okay, this needs to be something that we start up in Australia? What made you create Endometriosis Australia?
I think Jason Abbott and I had a chat a long time ago, and I was probably not in the right place either. Neither of us were. And then with my son, you know, getting him ready for school and getting him off to school, it was like, where do I put my energy? Do I put it into autism awareness, or do I put it into endometriosis? And people knew what autism was, but no one knew what endometriosis was. So I did knock on Professor Jason Abbott's door and ask him if he would come along on this crazy journey with me, and to shout from the rooftops and to make endometriosis a commonly said word in our homes and in our schools and in our workplaces and amongst our friends, to give those that live with this disease every day a voice.
You've been absolutely magnificent. You're so passionate and our illustrious leader. Why is it so important when it comes to fundraising to help with research?
Well, as we know with endometriosis, there's so much we don't know with endometriosis. So if we could have the appropriate funding for the size of the problem and the quantity of people and Endo Warriors out there that live with endometriosis, and that's not just the patients, that's also the families that's affected, and spouses and children that are always affected by living around someone with endometriosis. So we need proportionate funding for research so we can find out what causes it, how we can prevent it and how we can cure it, and how we can manage it better to give every Endo Warrior the quality of life they deserve.
The quality of life is an interesting one because you mentioned the family effects. And it's often something that I don't think about until actually on the weekend I had a bit of an endo pain flare-up and I was in tears, as normally what will happen, and I'll just say to my husband, I'm so sorry, I'm such a burden on you. And he just says, you know, Ellie, that's not the case whatsoever. But it really does affect your partners. If you've got children, I know that my mum and my dad, they feel really sorry and guilty almost that I've had to go through so much in such a short time. And that just really breaks my heart. And that's, you know, there's all these young girls as well. I recently went to my old school and I spoke to a group of women, and it was about my endometriosis journey. And I had, after doing the talk, these girls, 15, 16-year-olds, walking up to me in tears and just saying thank you so much for actually talking about it, because I've lost friends, my family doesn't understand how to deal with this, and it just really does break my heart. And that's why it's so important to have our Endo Warriors, who you mentioned, Donna, being a voice and just creating awareness.
Yeah.
Well, I think with statistics we know that those that have endometriosis and that they actually lose their friendship group the most. And that just breaks my heart to think that, you know, I was talking to someone who knew a 14-year-old girl that's lost all of her friends because, and had to move schools because of endometriosis. And, you know, if we can destigmatise what endometriosis is about, then we give those Endo Warriors around the country the ability to reach that potential, you know, reach their potential.
And it's cool that it happens at such a young age too. Yes. You know, it's your formative years, you're 15 and your friends don't want to talk to you.
Yep.
They think you're a loser. I can't help out with what's going on the inside. You know I don't look sick on the outside. And the other big thing too that it does affect is workplaces.
Yeah.
Now there's how many billions of dollars in Australia are lost because of endometriosis?
The cost to it's $9.7 billion annually, and that's cost to the economy, loss of productivity, and indirect and direct healthcare costs. So it's quite a significant amount that it costs the economy, and I just think of how much, one, we would save, one, we could, be contributors to the economy if we had more research and more funding to find out what is happening and why endometriosis is such a wily character.
And just by watching this symposium, you are helping to raise research funds, which we thank you so much for doing for. And the other, once again, back to workplaces, it also blows my mind too to hear that women are losing their jobs because they've got this illness. And it would be the same too, Holly. There'd be athletes who aren't able to reach their full potential because they're going through such a debilitating disease.
Yeah, I mean, like I said before, that obviously there has not been a lot of research surrounding it, and now that it is becoming a discussion, even women's menstrual cycles through sport, and basically all that was ever said was, just go on the pill, just go on the pill. That's the only, don't do that. Yeah, I mean, but and obviously, if you're, if you want to peak at a certain time, you are, doing everything you can to peak then. And if your period comes at that time and the endometriosis is really bad, then it's difficult. I mean, you wouldn't want that if you were showing up to the Olympics that day, would you? It's not really a thing, and it is a problem. But it is becoming more spoken about between athletes, and with physios and doctors, and as you say, the people that surround the people that have are suffering from endometriosis. It's not just the people that need to know. It's everybody should know, because it does in one way or another affect everyone. Everybody probably knows somebody that has it, whether or not they know that.
Yeah.
Now, Hoda, you've got 2 young daughters.
Yep.
Are you worried that they may have endometriosis, and how do you think you'll have that conversation if that happens?
Of course, I worry every day that they might suffer through the same things that I did. But I think the conversation that I'll have with them will be far easier, because I've experienced it myself, so I would know sort of, what to, help them to know what to expect. But also, I think nowadays it's becoming more, the word endometriosis is being spoken about more. There's still a lot of work to do in the area, but, the fact that doctors are knowing the word endometriosis, back in my day, not many people heard of it. And so at least they're in with a chance, at least to manage it, because, it is, I used to, I always say it's a horrendous pain condition that I didn't wish upon my worst enemy. So
it's a great way of putting it. Yep. You mentioned managing pain. You have a flare-up at home. What's your go-to?
My bed, it's number one, with a hot water bottle, and just I just need to zone out a little bit, with that pain. That's how I control my pain. Hot water bottle, and as long as there's something like touching the pain area, it's weird, but like skin, like even my hand just touching it, sort of makes me just zone in and go, yep, like I'm trying to psychologically get rid of the pain. Sometimes it works, sometimes it doesn't.
Focusing all your energies in on the pain. It's an interesting one, but I understand how it could work. Now, Donna, what about for you? What's your go-to?
Because I've got quite a few different presentations of endometriosis and I have it up in my chest, so I sort of have to manage it on a few different ways. Heat is always my go-to, so the electric heat pad, the wheat bags, all of those go to. I often have concurrent headaches or whatever, and I might have to go and have a lay down in a dark room at the same time. So that's usually my go-to. And I do recall, when you were saying about pressure, I do recall that was one of my first things that I remember being 16. When I look back, that was it. And I can remember my grandmother rubbing my stomach, and that was my comfort thing, was her giving that healing touch. I think it's just that, bit of love and a bit of empathy and affection at the same time.
It is weird when you sit here and you say, I've got endometriosis in my chest. You wouldn't think that something from your reproductive system had the capability of infiltrating any other part of your body. It's been found in some weird and wonderful places which Professor Jason Abbott has spoken about, including, the heart, the brain, the bowel's quite a common one, but it really goes to show you that it could take control of any part of your body.
Yeah, it's. I think it's a different mindset when trying to explain that to other people. That it's not the first opening sentence of "Hi, my name's Donna, and I've had part of my liver removed because of endometriosis." But I think understanding how your body works and why it is, for me, it's the muscles in between the ribs go into spasm, and how do I relax that? So, I do have my osteo and my acupuncturist and all on speed dial, but heat is my at-home tip.
Heat is a blessing. What about for you, Holly? Do you have a hot water bottle bestie?
I think the girls have it covered pretty much. Fetal position would be the only other thing.
Such a fun look too. My partner, Jamie, with my husband, will walk in and go, "What are you doing?" "Just in the fetal position. You know what this means.
Yeah.
Go away."
Yeah.
It's just the go-to. So let's flash back to when we're younger right now. Let's go in a little time machine. We're 15, we're 16. It's when we're first going through endometriosis, the first painful period. And I want to talk about, in hindsight, what would you tell your younger self?
For me, I'd probably tell my younger self not to push through the pain, and, would have seen a doctor earlier about it, and that it's not normal. So I think that's one big thing that I would have done in hindsight.
What about for you, Donna?
Believe in yourself. It's not at all in your head. Believe in yourself. You're not a hypochondriac. You're not the drama queen. Believe in you. And if you're not getting the answer that you need, keep searching. Educate yourself. I look back and think about the conversations I could have had with school friends. So Hoda keeps referring to herself as being really old, but I think I own that one on the couch. And I remember talking to a school friend at our 30th school reunion, and she said, "Oh, that's what I had. That's why I missed so much school." We were in class every day together when she was at school and had no idea that she lived with endometriosis. Wow. So I'm glad the conversation's evolving as the generations evolve, but that would be believe in yourself.
Yeah, that's a big one too, especially if you do to go to a doctor. And I had a scenario, very first time, I was 19 and I got told I was crazy and it was all in my head and there's nothing wrong with me. And when you get told that,
far out,
you go, and you question everything and you go, I'm not going to go back and see anyone. I'm just going to suffer in silence. And it really is an awful experience. What about for you, Holly? If we could flash back, what would you tell your younger self?
Pain's subjective, at the end of the day. And, being someone that spent a very long time ignoring the pain in my body just so I could get on with my career, basically, I think the important thing is to listen to what your body's saying, because more often than not, it's right and you're wrong, if you know what I mean. And so, and as you say, pain is subjective. If people come to me and say, something hurts, I mean, I could just laugh it off and be like, well, how many times have you broken your back? That's ridiculous. Of course that doesn't hurt. But, I mean, as far as they're concerned, that may be as painful to them as breaking my back was to me. It is 100% subjective, and you've got to listen to your body, and as Donna said, you've got to trust yourself and back yourself. And if someone's telling you it's not a thing, you tell them otherwise. And the louder you are,
you've gotten faster, haven't you?
The sooner you'll be heard. Yeah.
You really do have to believe in yourself and back yourself, and create conversations around as well with others, and get this chat going. Have some high teas and just start talking about endometriosis. And as we've spoken about quite heavily, research is key, and raising money for fundraising, because the research is the thing that's going to help us find out more about endometriosis. And I would hope that we find that cure soon.
Yeah.
Yeah.
Definitely.
For the next generations.
Yes. May not be for us, but the future generations, I'd love to be able to know that, hey, that just by being a voice that we've been able to do something.
Exactly.
Yeah. Hoda, Donna, Holly, thank you so much for your time on the couch today.
Thank you,
and for being so open and honest with your endo journey. and be great in future if we don't have to be talking about endometriosis. I know that that is the aim for Endometriosis Australia, to help get more fundraising for research in the future, and hopefully one day there is a cure.
One day.
One day.
For the 1 in 9 people who do suffer. Thank you so much again, ladies.
Thank you.
Thank you.
Thank you so much for watching this episode of our special symposium for Endometriosis Australia. If you would like any information about this illness, or if you'd like to donate, endometriosisaustralia.org is the place you need to get to.
Hello everybody, it's World Endometriosis Day. My name's Jason Abbott and I'm the Chair of Endometriosis Australia. I'd like to welcome you to this symposium, and today we're going to talk things all about surgery. And I'm joined in our Sydney studio by Dr Danny Chou, gynaecologist extraordinaire from the south of Sydney and a long-time friend.
Thank you, Jason.
Amani Harris, who's trained in both Sydney and Melbourne. Amani, welcome. Also from Sydney South. Dr Erin Nesbitt-Hawes, who works with me in Sydney's East. So this is our Sydney team, but we're very lucky to be joined in our Melbourne studio by Associate Professor Emma Readman. Hi Emma, how are you?
Lovely to see you, Jason. Thank you very much for inviting me.
Pleasure. And in Brisbane, we're joined by Associate Professor Anusch Yazdani.
Hello, Jason. Wonderful to be here.
Excellent, thank you. And it's a pleasure to have everyone on the team. What I want us to start with is just some general thoughts around surgery. And, you know, surgery is one of the treatments that we have for endometriosis, but it's actually a relatively short list of treatments. And I want us to think about why we would actually do surgery in the first place. So Amani, can you tell us about sort of the principles behind why surgery might work for someone with endometriosis?
Sure. So the aim of surgery in someone with pain or struggling with infertility is to remove or excise the disease, burn the disease off, restore the anatomy of the pelvis and correct any damage done to the organs as well due to the endometriosis.
Fantastic. So getting rid of all of that inflammatory tissue is, you know, a good way if that's one of the cause of the problem, either pain or infertility. Super. And so what's the best approach then for surgery, and what kind of qualifications do you think you need to be doing this kind of thing?
So nowadays, the gold standard for surgery is to adopt a minimally invasive approach to benefit the patients from improved recovery, less post-operative pain and less complications, and that would be via laparoscopy or robotic surgery. And the qualifications are one must be a trained gynaecologist, and the Royal Australian and New Zealand College of Obstetricians and Gynaecologists has outlined what it believes are the recommended training pathways. So it would expect a generalist to have competency in excising endometriosis stage 1 to 2, but surgeons that have taken on further accredited training program like the AGES 2-year fellowship would be expected to achieve competency in more severe or complicated level 3, level 4 disease.
Anusch, I'm going to turn to you because you've been the Director of Training for AGES for many years. And what other things do you think need to be considered when you're talking about qualifications in this type of surgery?
Well, look, really the important issue here is that Australian women should be very comfortable that their gynecologists have been specifically trained in the management of endometriosis. And internally really is where the pathways flow. So our training now goes beyond just the basic assessment of endometriosis, and for more extensive disease, most of that training occurs after the completion of the fellowship. And your gynecologist that you would be seeing would be able to then say, hey, look, this is beyond what I would do, and would then refer you to a specialist in this area.
So it sounds like there's, you know, variable pathways for training, and not everyone's going to have exactly the same training. So what factors should patients consider when they're looking for an endometriosis surgeon? Anyone?
I think you have to look at surgical volume and the number of cases that a gynaecologist is performing, particularly when it comes to more advanced stage disease and complex cases, and whether or not the surgeons are working as part of a multidisciplinary team and are involved with colorectal and urological colleagues. I think those are important considerations, particularly for women where disease is perhaps a bit more extensive expensive and not able to be excised easily by a general gynaecologist.
Fair enough. And so does that mean that, you know, if I'm not a gynaecologist, say I'm a general surgeon and I'm doing a surgery, say, for an appendix, am I likely to be able to always see endometriosis in the pelvis? Is that something that, you know, everyone should be able to identify at surgery, or is that a slightly more tricky thing?
I think general surgeons aren't necessarily trained to diagnose endometriosis. They're probably able to diagnose more advanced stage disease that can be quite obvious, but a lot of them don't always look in the pelvis whenever they're doing a surgery for a different reason. And even within the gynaecological specialty, the lesions of endometriosis can vary very differently, and some are very subtle, and I think they can be even difficult for a general gynaecologist to diagnose at times.
Right. And I guess there's probably a spectrum of disease too, right? You know, sometimes within the same patient you might have differing levels of disease, even within the same patient. So, you know, we don't always recognise it ourselves, I suppose. It's hard to expect that everyone's going to be able to identify, particularly those very, you know, little and subtle lesions. So, Danny, can I ask you,
Sure.
when should people be offered surgery for endometriosis?
People should be offered surgery when their symptoms are not easily controlled by simple medical treatment like painkillers and hormonal treatment. So this is when we feel that surgery might be the way to get them to feel better. Sometimes we will operate when there's a big pathology like big ovarian cyst that might rupture and cause harm to the ovary if it's not treated. Sometimes we will do removes blocked tubes when somebody needs an IVF that could impact on the outcome of IVF. Or when patient is concerned about the possibility of having endometriosis, I think you have to deal with that as well. Yeah.
Is everyone comfortable with, you know, that kind of thoughts on who should be when we should be offering surgery? Beautiful.
Yes, Jason, I think Danny, they're excellent ways of thinking about it. Really, we want to emphasise that we don't generally operate on people who don't have any symptoms. We like to have people who have symptoms who are operated on, or if there's a diagnostic dilemma and we find it difficult to work out which way to go, sometimes surgery then would be a really important way of making a decision.
So, Emma, if I just pick up on your point and we're not operating on people who don't have symptoms, what if they seem to have disease, say we pick that up on an ultrasound or other type of scan, would we be offering disease to prevent progression? And maybe I can ask Erin whether we should be doing that.
I don't think we should be offering surgery to prevent progression of endometriosis necessarily. Endometriosis can progress in a number of different ways in different women, and probably there's genetic factors as to why endometriosis behaves differently at different times. And progression itself may be moderated by medical treatments and things like that. So I don't think that should be a primary reason. There needs to be a driver which, as Emma said, you know, would normally be symptoms of pain or fertility issues. So
some careful selection along the way, and probably a discussion with the person, making sure that they understand all of the risks and benefits. Does that sound like a fair summation?
Good.
Absolutely.
Beautiful. What I'd like us to think about now is just a little bit more on fertility. And, you know, first of all, because we're talking about surgery, does surgery improve or decrease chances of fertility? Amani, I'm going to turn to you for this one.
It can do both, depending on the surgery. So obviously it would not be appropriate to offer someone who is wanting to try and conceive a hysterectomy, which can be an option for some women with pain. But otherwise, if we are doing surgery to improve someone's fertility or chances of spontaneous conception, which it can, then that is a good reason to do so. Where we need to be careful is when we're operating on ovaries in terms of fertility. Endometriomas already reduce a woman's ovarian reserve, and further surgery does that also. In fact, operating on bilateral endometriomas has a very small but real risk of putting someone into menopause, which is a devastating outcome for someone wanting to fall pregnant. So we need to be careful. Technique comes into it, and knowing when to operate and when not to operate on patients is very crucial.
So taking care of the ovaries, that's
Exactly.
that's the kind of take-home message
Yes.
that I get from that. Anusch, you're a subspecialist reproductive endocrinologist and infertilitist, so this is definitely your area. What are the limits on fertility improving surgery?
Yeah, thanks, Jason. Look, I think we have to remember that fertility is about three factors. It's about the sperm, it's about the egg, and then it's about the reproductive organs or the pelvis. So obviously any pelvic surgery is not going to fix sperm problems. And I think that's one of the things we have to remember when we're talking about fertility. And even if we confine ourselves to endometriosis-related infertility, we need to remember that in that situation, in fact, the problems occur on different levels. There's the anatomical distortion, which interferes with the sperm and the egg coming together. There's the pelvic environment and that awful inflammation. There are functional changes that we know that women with endometriosis have, like altered response to hormones. There's the endometriosis treatment itself, which stops women from ovulating often. And of course, then there's pain. People who have pain don't have sex and therefore have problems falling pregnant. Now, surgery improves some of those aspects, but not all of them. And I think that's a very important component of what we need to remember.
So it's complicated, or it can be complicated depending on the situation. Is that right? Good overall view? Mm-hmm. Sounds complicated to me. Amani, you mentioned before that we really want to take care of the ovaries, and that the ovaries are a delicate area. Can you tell me some of the other risks that might be associated with surgery for fertility?
Sure. So like any laparoscopy, laparoscopy for endometriosis has the similar risks, but it is unique surgery, and the risks really vary depending on the severity of the disease. So we know endometriosis causes adhesions and makes organs stick together. So when there's surgery relating to bowel disease or involving anatomy such as the ureters, then unsticking those organs can risk damage to that area. And also remember, the pelvis is full of nerves, so there can be damage to the nerves, and that can have long-term risks, real risks like damage to function of the bladder or the bowel, problem with ongoing pain. There could be risk of injury to major blood vessels if one is not careful. So the risks really increase with the severity of the disease and the complexity of the surgery.
Right. So take care on very severe disease, always be aware of risks, and always have that conversation and look out for them.
Absolutely.
Fantastic. And Anusch, if we take into consideration some of the things that Amani was talking about, just in terms of complications, what about alternatives then to surgery for fertility?
Yeah, well, look, the significant alternative is assisted reproduction. And in Australia, really, this means access to IVF. But it's really not always, and should you be doing surgery or should be doing IVF, they're often complementary approaches. The decision as to whether or not you proceed to surgery, as we've said already, depends on the expectations of the woman, on the expectations of the family, the resources and her aims. And therefore, there's not one simple answer. It's really quite complicated. And in each situation, we should individualize the treatment that we offer patients.
Emma, we spoke a little bit earlier about not doing prophylactic surgery for progression of disease. What about for future fertility? Is that the same story? Is that a different story?
Well, it is the same story. We really don't want to cause a complication where we don't need to. If someone's got no problems at the moment and we do a laparoscopy, and as Armani said, we cause a complication, they're not going to thank us for it, really, because they've been well. The only thing we could consider really is whether we want to preserve ovarian function, and we may go and take some ovarian tissue in order to preserve that, just in case they wanted to use it in the future, and that might be a really good thing to do. But apart from that, in general, we wouldn't do prophylactic surgery for IVF.
Amani, have you got any other thoughts? Thank you.
I think that's perfectly said by Emma. And I think the only extra thing that I might add is, for example, a woman with an endometrioma, even if it is asymptomatic, maybe not in the context of fertility, but maybe someone that we'd like to monitor or maybe consider excising that cyst now that we know if it is present or if there's any atypical concerns or anything we're worried about.
So we've seen an increase in things like fertility preservation, people being offered egg preservation. Is this something that we should be considering for our patients who are going to have surgery? I'm going to talk to Erin and Anusch. I'm going to come back to you after that as well. I know, we've got two states and maybe we can have a state of origin type clash here, see if who's going to come out on top. Erin, let me start with you.
I think it comes down to the fact that all women are different and their situation is going to be very individual and unique. And I don't think it's fair to say that we would offer all women fertility preservation before any endometriosis surgery. We know, as Amani said, that having endometriosis on the ovaries is something where the surgical process may be detrimental to that ovarian function, and those women or women who are perhaps older or are not in a current situation where they're actually considering trying to conceive, definitely I think we need to have that conversation and we need to see what their baseline fertility levels are like and how they might be impacted. But I don't think we can say it's a one-size-fits-all type of rule.
And in the Maroon State, can we go north of the border where it's beautiful one day and just even more beautiful the next? Anusch, what do you reckon?
Well, I actually would go a little bit further. I think that fertility problems are one of the cardinal signs of endometriosis. And I think if you're operating on a patient with endometriosis, you really need to be assessing their fertility. So part of the baseline assessment these days really is doing an assessment of the ovarian reserve. And if they have risk factors like age or they have a low ovarian reserve, fertility preservation should be discussed with all patients in that situation. So I think we've moved beyond it's one of the things that happens with endometriosis. It's now predictable. We know that women with endometriosis have a lower ovarian reserve. There is an association, and it should be assessed in all patients with endometriosis. The converse is also true. All patients with infertility, you should be considering endometriosis, particularly if there's no other factor found.
And so we mentioned before the ovaries and the importance of the ovaries in the whole process of fertility and improving fertility by doing a surgery. But what if the endometrioma comes back? What if we are considering doing a second surgery? Is that going to be beneficial or not to future fertility? Anusch, just start with you.
Yeah, look, I think we have good evidence now that repeat surgery does not improve outcomes. So we should really be, particularly from a fertility point of view, your first procedure is your greatest opportunity to address the problems. And repeat surgery really then needs to be on a goal, in a goal-orientated way. So often we have to then separate, is the problem here now fertility? Do we want to aim for a pregnancy, or is the problem here pain, and do we need to address them? But repeat surgery has not been shown to improve fertility both spontaneously and with assisted reproduction.
Erin, you have the opportunity to come in for the Blues and score the winning try, take out the series. Anything to add to that, or are you happy with Anusch's answer? Can we say that he's okay?
No, I think I agree with the Maroons today.
Wow.
That, yes,
it had to happen eventually, didn't it? So what is the right number of surgeries for someone who has endometriosis?
Again, I think we can't say that there's a right number. I think the right number is the lowest number for each individual patient that we have, and ideally we need to be performing fewer surgeries on women in general with endometriosis, because we know there can be harmful effects of performing multiple surgeries. So there's no right number. You know, we need one perhaps for diagnosis if we're going to talk about surgical diagnosis, although in many women a clinical diagnosis is very valid, and if those symptoms are then treated with medical treatments, we may aim for 0.
I think so 0 to something slightly higher than 0, but probably not nearly close to 100, right?
Not close to 100.
And so what's the scientific support for repeat surgeries? I mean, is there any evidence that if we do a second surgery or a third surgery, what's the science that tells us, are they getting any benefit from that?
Again, with repeat surgeries for fertility, I think that there's very limited data to support multiple repeat surgeries in endometriosis. That doesn't mean that repeat surgeries shouldn't be done, and there are certainly some contexts in which repeat surgeries can be beneficial for pain reduction, or if we're considering moving towards having a hysterectomy or a different surgical procedure. But there are certainly, you know, a bit of a dearth of data around whether or not women are likely to get benefit, and there certainly are risks associated with it.
Danny, I mean, you do a lot of complicated surgery and get a lot of referral for very complicated situations where people have already had surgery. I mean, you're probably already doing repeat surgeries. What's your experience and thoughts?
Yes, I think sort of we go back to treating patient symptoms, and I think if the symptoms stay, you can go for surgery, but you want to be very sure that when you do a second surgery, you take everything and anything out, and you can put a stop to it. So if there's no pathology, it's a medical treatment. So I'll refer to you and look after chronic pain. So I think it's just, I think just trying to minimize the number of surgery.
So listening to the patients, trying to work out what their symptoms are, and then progressing with a plan.
Yes. That's
perfect.
Right. And that might not be surgical, yeah?
And it might not be surgical. And I mean, surgery, you know, we hear about this process of central sensitisation.
Yes.
And I think it's one of the issues that we face after surgery. So what is central sensitisation, and does it occur to everyone? And is that something that can be prevented? Erin, can I just ask you first?
Well, central sensitisation is where the nerves, particularly in the pelvis, but it can occur anywhere in the body, but for women with endometriosis, it's the nerves in the pelvis that are altered in terms of the way that they behave. Endometriosis causes a number of changes within nerve fibres in the pelvis. Primarily, it increases the proliferation of those nerve fibres, so women with endometriosis have many more nerve fibres, but they're also more sensitive, more likely to receive information, and then that information is amplified. So the signals to the brain are in excess of what they should be, and often they are only pain signals, and that can be from normal functions of the body, like the bladder, the bowel, ovulation, that become painful over time, and that's because of this process of what's happening to the nerves.
So a little bit like turning the volume button up on the stereo. Sometimes
Correct.
It's just getting a little bit too loud and, you know, causing havoc with your ears. Emma, I know you work in a tertiary referral centre in Melbourne that deals with a lot of pain, a lot of central sensitisation. Have you got any thoughts on that, and, you know, what things that we need to be looking out for in terms of that process of central sensitisation?
Yes, central sensitisation is something we've really become to appreciate a lot more in the last 10 years probably. We realise now that pain signals can be turned up, as you said, and small pain or no pain can become big pain. And that's something that we need to be aware of to try and prevent it. So one of the things to prevent it is just to get onto pain early. So try and diagnose pain earlier so that it doesn't get to become persistent, and therefore these overactive nerves can be present. But also perhaps sometimes we might decide not to operate, because sometimes when we operate, we're part of the problem. We can turn up these nerves by the simple cutting of the abdominal wall or cutting of internal organs. So sometimes we can say maybe we would not operate on someone who had a lot of central sensitisation. And as I said, otherwise we would get onto it early and try and treat it with some sort of nerve-based agents to reduce pain. These also can be helped with muscle-based therapies.
So we need to be fairly judicious in who we do surgery on, particularly if they're showing some symptoms that kind of tell us that their volume button has been switched up, as it were. Is that an appropriate kind of summation of what you were saying there, Emma?
again, perfect, Jason. I wish I were you.
Don't we
No,
all?
you don't. I'm sure you don't. You really don't. But I do have a question for all of you, because we've been talking about repeat surgery, and I wonder what everyone thinks is the shortest time interval that we should consider between surgeries. It's a controversial thought. Danny, I'm going to start with you, kind sir.
I think probably maybe leave it for a year or something, I'd say.
At least a year, Amani?
Yeah.
I second that.
A second.
I'd
Erin, just
be
'cause I'm
pushing
here.
it out.
You're pushing it out.
Yeah, I think if you've removed all of the disease at the index surgery, then I'd be aiming for more like 2 years before you go back in.
Let's go to Melbourne first. Emma.
Melbourne has the best things to say. Thank you. Well, essentially, I guess there's only one time I could think of where I could do it very frequently, and that is if you had you did a diagnostic procedure, then you might say, oh, look, I'm going to stop, and then I might come back a bit later and do the definitive procedure. Or another thing would be perhaps you drained an endometrioma, you wanted to give them Zoladex, and then come back 3 months later to operate on them. That sort of thing would mean that perhaps the procedures were closer together. But essentially, we should be thinking less surgeries on less people less often.
So fewer surgeries and, being careful. Finally to Brisbane. Finally, but definitely not least, Anusch, of course.
Look, I think I can only echo what the rest of the panel have said. If the last surgery has been complete, then I would be looking for reasons to go back again. I certainly wouldn't be looking at that in the year to 2 years. Now, it doesn't mean that you tell the patient that they have to put up with her symptoms and with her pain. It means supporting them, but it just means it's unlikely to be surgical.
And so can we always remove all endometriosis every time we do a surgical procedure? Let's go with Brisbane and Melbourne here. Let's start in Melbourne. Emma?
Oh, thank you for starting with me, Jason. I feel important. Lovely.
Because you are important.
Thank you very much. Look, there are things that you might decide to do in a surgery and not. The first thing may be that you might decide just to do a diagnostic procedure to work out the lay of the land, and then come back later to do a better definitive procedure done at the right time. So that's sometimes when we go in, we might find that there's unexpected findings, things we didn't anticipate. And then again, we might stop and come back at a later time. Essentially, what we try and do is do the definitive procedure so we don't destroy the tissue planes and make it harder for ourselves and for our patients, and then try and do, as I said before, as little surgical procedures as possible, but properly.
Anusch, anything that you wanted to add to that conversation?
Yeah, look, the only thing I would say, particularly because this is Melbourne data, that disease doesn't always have to be cut out. While we try and resect endometriosis, there are good reasons for not always doing that. And certainly we know that the information is that on some parameters at least, ablation can be as good as excisional surgery.
So maybe what we're really aiming for there is getting rid of the disease in the safest possible way to get the best outcome for the patient's symptoms. And that's going to have to be, very dependent upon the training of the person. Is that right?
Correct. That's absolutely right. So I don't think that I do see patients who are sent to me because their specialist didn't perform an excision of the endometriosis. And when you have a look at the images, and we always encourage people to keep images. And when you look at the images, you see that there is actually no evidence of any residual disease. And so I don't know that I would force everyone. I know I would not go back into surgery to go and resect something that somebody else has very nicely ablated and removed the disease.
I think, the key there that you mentioned, Anusch, was really about having capacity to look at some of those images. That can be really helpful for us if we're giving a second opinion, because, then you can see whether the disease was removed, and the method is not necessarily always the absolute end result of that. So we talked a little bit earlier about staged procedures and using a bunch of different techniques that might be helpful to think about a complicated pelvis. And there's probably times, Danny, you've probably come across this before, where you've got a complicated pelvis. What do you think the processes are that go through your head that decide that might be the right thing to do?
Yeah. Endometriosis surgery has become very sophisticated, and there can be, multi-organ involvement. And say, for example, if there's a lot of disease in the pelvis and there's a thoracic problem, so sometimes people will be recommending to have pelvic disease done, and then sort of maybe thoracic will be a second stage. Sometimes we would do leave a right bowel, sort of a left compared to a kidney problem, so it's a stage. Sometimes if a person has a bowel disease but has no symptoms, if they have ovarian endometrioma, then we can deal with the ovarian endometrioma and not touch the bowel if there's no symptoms. So very symptom specific. I think it can be kind of limit your surgery to what the patient needs.
This is a really, recurring theme, I think, that we've heard a lot tonight, and I'm really glad to hear it about the symptoms and just keeping your ears open to the patient. Amani, you've been doing complex surgery like this for a number of years. What do you think about sort of staged procedures?
I think Emma touched on this a little bit also. It's really important, for example, if a patient has large endometriomas, the larger the endometrioma, we talked about the importance of preserving ovarian function. So the larger the endometrioma, the more likely you are to strip follicles from that ovary. So a staged procedure would be really good. So firstly, first time drain the cysts. That would immediately alleviate some pain. Use medication such as Zoladex to then shrink it, and the next time you go in to strip and remove that cyst, or perhaps a patient may even have a cycle of IVF in between before surgery, then you've really done well to preserve the function of the ovary and remove less follicles.
Beautiful. So it sounds like we are starting to think less about surgery as kind of this isolated situation and more about it as part of the rationale for what we do with our patients with endometriosis. Does that sound like a fair assessment?
Yes.
Yeah. So what about hysterectomy? We hear a lot about hysterectomy. Where does that fit into the discussion? Is it kind of more or less successful, particularly in people who maybe have had more endometriosis surgeries in the past? Amani, can I start with you?
So one thing we need to remember about endometriosis is also its cousin endometriosis, which is adenomyosis, which occurs in the uterus and is very common amongst patients with endometriosis and has its own set of symptoms that hysterectomy works really well for. So in fact, most patients that undergo hysterectomy for pain have a really good result and are really happy with their surgery and have really low chance of regretting going through the surgery, even if they have ongoing pain. The best predictor of pain after surgery is having had pain in the past. So that's the problem. So, and also
a common presenting symptom for many of our patients,
exactly,
though, right?
Yes. Hence, judicious use of surgery in this population.
And remembering that, surgery is just one part of this whole big picture. So, we're not just thinking about surgery all of the time. We're thinking about medicine. We're thinking about this in context of all of the symptoms and what we can do maybe in a non-invasive manner.
Yep.
So, is surgery helpful for all endometriosis-associated symptoms? Anusch, I might just come to you because Amani was talking, very much about that horrible cousin adenomyosis and where the disease has started to invade there. What about for endometriosis-associated symptoms? What do you think about hysterectomy and that problem?
Well, I think the simple answer is that the only thing that we can guarantee with a hysterectomy is that there will be no further menstruation, there will be no bleeding. What the impact will be on the other symptoms depends on the nature of the symptoms and it depends on the problems. And as we have said before, very important that just removing the uterus in this sort of situation may not fix the problems because the uterus may in fact no longer be the only issue. If you're going to leave lots of endometriosis behind, you're going to continue having problems. If the issues are cyclical symptoms, and we are all much more conservative in our surgery than my teachers were when I learned to do excisional surgery, is we're much more likely to leave ovaries behind for very, very good reasons. But sometimes those cyclical symptoms will continue and we need to manage each symptom on its own merits, knowing that, as you've just heard, predictors for post-operative pain are preoperative pain, And it's just the first stage in the management. It's just part of the armamentarium. It's not a one-stop solution.
So we've heard about adenomyosis and endometriosis, and those two terms are often used interchangeably. So are these the same things, Emma? Are they similar, or are they just completely different entities?
Thank you again for this lovely question, Jason. Endometriosis, as we all know, is where the lining of the uterus grows outside the uterus. But what if it grows in the wrong place in the uterus? So imagine if it's not in the right place, but it's tracked back into the muscle wall. So that's what adenomyosis is. It's the glands and the lining of the uterus in the wrong place, but still within the uterus.
Super. I like your answer. It's really quite clear. And so if we did do a hysterectomy, Anusch was mentioning before that, there wouldn't be any periods, and that makes sense because we're getting rid of the organ that menstruates. But what are the symptoms that are most likely to be improved? Amani, can I start with you?
So often symptoms that come from the uterus causing pain are things like pain during intercourse or dyspareunia, pain, heaviness in the pelvis, lower back pain, pain that radiates down the legs. So they often are improved greatly after a hysterectomy.
Erin, any other things that you can think of?
I think Anusch and Amani have covered it, and really the sort of pain that's associated with a period pain may be helped by having a hysterectomy.
So no periods, no period pain.
That's right.
It's always a good adage, isn't it? But it's, you've still got to take into consideration all of those other issues and all of those other problems, and thinking about other causes of pain too, because it's not always just the uterus, not always just the pelvis, not always just the gynecological organs. So
Jason, I think you're right. This is probably the big change that we've seen in the last 5 years, that hysterectomy is no longer the panacea for pelvic pain. And I think the times where you could just perform a hysterectomy and then tell the patient, well, you're cured now, goodbye, I think are well and truly over. And I don't think any of our patients should expect that from their care providers.
Yeah, I think that's important, Anusch. And certainly we shouldn't be telling them that this is going to be curative and it's going to solve all of their problems. So if they have had a hysterectomy and they still have ongoing symptoms, Erin, what things could we do? And what if they come back? Should we be taking their ovaries out as well?
Well, I think in the majority of the cases, it's not necessarily the next thing to take out the ovaries, and it comes back to the condition of central sensitisation and what else is going on within the pelvis, within the nerves and the muscles, and whether or not we can address those causes of pain in that individual patient to help improve those outcomes. I think one of the ways which we often use to help try and really work out whether a woman's pain is going to be due to her ovaries or some hormonal variation versus the nerves is that we can induce a menopausal state medically and see what the response is in terms of symptoms, and that gives us a reasonable outlook for if we were to remove the ovaries, which sometimes can be applicable, then what benefit would the patient get? But there are many downsides from having your ovaries removed, and not the least of which is a shorter lifespan. So I think we really need to account for that in terms of what we're likely to achieve.
So another take-home message is very much be careful with those ovaries. Anusch, I think we lost you just a moment there. The satellite fell out of the sky over Brisbane, but I think it's back on.
It's raining.
It's raining? It's raining everywhere. It's terrible, isn't it? What I want us to do now is just move on to some maybe less common types of surgery that we do with endometriosis. Endometriosis has been reported all over the body, but I just want to ask everyone, what's the strangest location that you have seen or heard of endometriosis occurring? Danny, let me start with you, young sir.
I would say sciatic nerve endometriosis.
Disease in the nerves.
In the nerve itself.
That sounds very uncomfortable.
It's very strange. It is. Yeah.
Anusch, in Brisbane, you see all kinds of strange things.
Yeah, look, unfortunately, the lungs are probably one of the most difficult areas and often presents as cyclical chest pain or in fact coughing up blood. And so that's a very difficult diagnosis to make and also a difficult treatment.
Amani?
The spine.
The
Cyclical
spine.
back pain. Yep, took a while to tease that one out, but yep, the spine.
That's definitely a weird place to get it. We certainly, I wouldn't want endometriosis in my spine.
No one does.
No one does. Emma, what about you? What's the strangest place that you've ever seen or heard endometriosis?
Well, I had one poor lady who every single time she had her period, she bled out of her belly button. And we had a look in her belly button, and right at the bottom there was a lovely nodule of endometriosis. And when we did a laparoscopy, there was nothing underneath it. So it was an isolated nodule of endometriosis in the belly button.
It's a strange, strange disease, this one. Erin?
Well, similar to Emma's, endometriosis in a caesarean scar, so patient having pain along their scar on a cyclical basis.
So this is a weird disease, right? If you know, it's supposed to be benign, it's not cancerous at all, but yet it turns up in all of these weird locations, in the lungs, in the spine, all of in nerves, and in skin. You know, I think that this is, you know, terrible. But we do commonly see endometriosis in the bowel and sometimes even in the bladder, and that can lead to symptoms. But you know, we don't really think of the bladder and bowel as a gynecological domain. So whose disease is it in this situation? Emma, let me come to you in Melbourne.
Well, thank you very much. And we do see a lot of this type of disease. So we have developed a very nice phone a friend situation where we have very good colleagues who are colorectal surgeons and neurological surgeons who we've developed excellent relationships with. And we would have multidisciplinary meetings with them before the operation, and we would go in and help each other to do the difficult procedure. But look, the most important thing to say is we're the ones who see endometriosis a lot. We understand it. So we, the gynecological surgeons, should be the ones setting the pace and saying what we should be doing and when we should be doing. And the colorectal surgeons have the expertise in the actual surgery itself. So it's a perfect marriage where we can really help each other.
Danny, you do a lot of this very complicated surgery, and you know, you're a very skilled surgeon. Is this a turf war? Should we be worried about this?
I think it's a team sport, and I completely agree with Emma. And I think we understand endometriosis a lot better. I would sort of, sorry for the description, but I would project manage, but I would get the colorectal or urologist to come and do what they're good at, you know, dealing with pathology in that particular part of anatomy. But we should be, I agree with Emma, we should be leading at control, basically treating.
And can we always, you know, I mean, if it's there, if there's disease in the bladder and bowel, should we always be able to plan for that type of surgery? Danny, can I start with you again?
Most of the time, I think nowadays we have a lot of advances in diagnostic, particularly with ultrasound. So, you know, people who deal with endometriosis, we're looking out for specific symptoms like bladder and bowel. So any hint that there is something, we should work them up really thoroughly. And we'd like to, like we said, minimize the surgery. So if there is something, if we identify, we should plan it. And also it comes down to the symptoms as well. So if there is no symptoms, there's a bowel, then maybe you shouldn't be doing so. It's a complex disease and it's very sophisticated the way we treat. So we should be trying to plan ahead. So we might not decide to do surgery, but should be able to know what we're dealing with most of the time.
Emma, how about you? Are you planning your team sports?
Again, an excellent question. We have the luxury of having a multidisciplinary meeting with our colorectal surgeons and our radiologists, including the ultrasound and the MRI specialist, once a month, where we put up all our cases of those people who are difficult, and we do a plan and we put the plan in the patient's history. And then we can then discuss the plan with the patient when we see them, and we know whether to bring the colorectal surgeons along, whether to have them on standby or whether to do it ourselves. And we've done a number of studies, and we're about 95% we can anticipate it from the preceding planning meeting.
So planning makes it perfect, and it means that you get to reduce the number of surgeries, and the patient knows what they're getting at the end of the day. That's that's really what we're aiming for here, having the patient understand and know that when she comes out, there's going to be certain things that have been done and the team's already organised. Is that how I'm hearing the planning discussion?
Yes, very much so.
Beautiful. Yeah. Anusch mentioned before finding endometriosis in the chest, and we've heard about thoracic endometriosis, but Amani, can I ask what is thoracic endometriosis and how common is it?
Sure. There's actually a syndrome, Jason, called thoracic endometriosis syndrome, and that includes endometriosis outside the abdomen or pelvis, which is commonly what we think of as endometriosis. And that can occur in the diaphragm, so the muscle between the chest and the abdomen. And it has two components, so one in the abdomen and one in the chest, the lungs themselves, or the lining of the chest cavity. It's not that uncommon, so up to 12% of people with severe endometriosis often have disease outside the abdomen. Whether or not we diagnose it, that's different. It can be tricky to detect. And Anusch mentioned some of the common symptoms that people present with.
So when you say 12%, you're talking about 12% of the severe end of disease, so not 12% of everyone who has endometriosis.
No.
Just want to clarify there.
That's a big number.
It's a very big number.
Yes.
So if you've got severe disease, you want to think about different kind of locations and where you might find it. And you mentioned their diaphragms and them being frequently involved in endometriosis and probably more commonly than the lungs.
Yep.
And so is disease on the diaphragm, say, and you mentioned that there's the tummy space and the chest space.
Yes.
Is disease on the tummy side the same as the chest space or is it different?
It's different. So it's occurring in a different cavity altogether. We often, whenever we start a laparoscopy, in fact, the first place we look is also in the upper abdomen. So we're looking at those organs, we're looking behind the liver, onto the diaphragm, more often the right side than the left, more commonly, and that's so it's easier for us to diagnose or detect, whereas the chest diaphragm disease tends to need different imaging and different investigations into the thoracic cavity.
Great, thank you so much. What I want us to think about is really the future of endometriosis surgery, and I'd want to ask everyone, where will we be in the future with regards to surgery as it stands in endometriosis care? And Emma, I'm going to come to you in Melbourne first. Where's the future of endometriosis surgery?
That's the first time a Sydney side has come to Melbourne first.
I would always come to Melbourne first. I love Melbourne.
Thank you very much. Look, hopefully the future of endometriosis is not a surgical solution. Hopefully we'll come up with a non-invasive diagnostic tool. We'll be able to pick it up early, treat it with some magic pill and never do anything surgical. That's hopefully how we're going to end up. At this stage, though, we've got what the future should look like is the least amount of surgeries on the least number of people.
Erin, can I come to you and ask you, where's the future?
Yeah, I agree with Emma in terms of the aim is really moving towards fewer surgeries, potentially better and more targeted surgeries, so trying to do the best job for that patient in an individual surgery or in a planned stage procedure, rather than necessarily going back on multiple occasions.
So, I mean, we have seen a big change in surgery, particularly over the last 20 years even. You know, we can take things out all over the body, and we've spoken about chest and bowel and bladder. Danny, are we as far as we can possibly go in terms of surgical technique?
I think that's a very good point. I think we come a long way compared to what we used to do. We do a laparoscopically and we do things, and I think there's rooms for us to fine-tune our surgical technique. I think we talked about ovarian cysts, how harmful it can be. And I think there's different things that have been tried, sort of alcohol, laser ablation and things like that. So we're trying hydro-dissected the cyst wall to minimize cauterization and all these things. I think another big thing about the nerve is a bit of a new thing, and also how the bowel is managed. So the bowels are usually sort of treated either shaving, disc, and resection, and we publish a paper about shaving. So that's we want to be minimalist. So mentioned before about bowel resection, that can be quite harmful and affected the bladder, bowel, and sexual function. So we're trying to minimize. So I think there's a lot of things that we can fine-tune the surgical technique to make it even more minimalist than what we have. I think there is room for improvement.
I'm hearing less. Yes. I'm hearing keeping our brain open.
Yes.
And I'm hearing more research, good technique.
Absolutely.
Excellent studies. Is that great? Perfect.
Yes. Fantastic.
Anusch, what's the next big innovations in surgery? Where are we going to go to in that crystal ball that you're gazing into?
Jason, I think we're going to see the same pattern that we've seen in other industries. And obviously in my other area has been infertility. And what we're really going to see is we're going to see the work in artificial intelligence and machine learning algorithms. We know that the current risk stratification that we perform to tell women who should have surgery, when and by whom and where is limited. And those multidisciplinary meetings are excellent, but I think there is room for improvement, particularly by picking out specific risk factors. From a technology point of view, really the next frontier here will really be remote surgery. This will give women access in remote communities and areas, access to surgery that they don't have in other areas. And we're talking about having specialized endometriosis care, and that it's not just about the surgery, but the surgery is an important component. And particularly in Australia, in our communities and the remote communities, it is just not possible to get those techniques in. And we're hoping that certainly with advanced robotics and with technology, that we will see this. And it will probably tie into what we've at least learned as part of the pandemic, is that you can have virtual meetings, we can have virtual consultations, and your virtual clinic will come to you. And I think this is where we will see the next big change.
So thinking about equity of access, and certainly Australia being such a huge country, that's going to be so important, just to make sure that everyone is receiving optimal care. So how do we know whether we're doing the right thing and maintaining best practice when we're doing surgery? Amani.
Rigorous data collection, so having and keeping track of what we're doing, and then analysing that data and comparing it to other institutions, to best practice around the world, nationally, internationally, and making sure we're always improving.
So it sounds, we mentioned before about, logbooks and keeping a track of cases, but it sounds like this is an ongoing practice that has to happen. Yep. And having good data, sharing data, because I think that's the other important thing. We should be keeping track not just of ourselves, but sharing that with other people. And that's going to be a good way for us to try and find some of these answers. So, big data collection is going to be so important. And what do you hope will be better for the patient with endometriosis having surgery in the future? Erin, can I come to you to start with this one?
Look, I think we should be hoping that more women have access to the best treatment for their pain. I don't think that necessarily means surgery for all women, but it certainly means access to surgery where they might not have otherwise been able to easily get that access, and have access to multidisciplinary teams who can manage pain and surgical techniques in different ways.
Danny, what's your hope for the future?
I think when we deal with a lot of complicated surgery, we just feel like that it would be nice to be able to diagnose early. So there's a lot of things, medical therapy, early diagnosis, more understanding about the disease progressions and things like that. So it would be nice that we one day will not have severe disease that we need to operate. So somehow stopping that progression would be nice. I think a robot will, like Anusch says, it's going to be a part of surgery, and generally, hopefully, a safer surgery.
Making ourselves redundant in future because they don't need our skills. It sounds like an absolutely perfect thing, doesn't it? Emma, what about you? What do you hope for the future in surgery?
Well, you said it perfectly. I hope we make ourselves redundant. I hope that we work out our diagnosis, we work out our medical therapies, we treat people early, we do as few surgeries as possible, and the patients don't have endometriosis as really a big part of their lives. It's just a background thing that they've had in the past, which is solved, and they move forward.
Amani, the future? You're young. We've told you we want to be redundant, but
Yes.
that's fine. We're old. But what about
Right.
you? You're young.
I hope we can increase awareness by doing panels like this for the entire community, and I hope the days of women taking years and not being heard are gone, and I hope that they no longer suffer and that we can be a part of that.
I think awareness is where it's at, and it's thanks to organisations like Endometriosis Australia that we've really pushed awareness throughout the country, both with our patient community but also with clinicians, and not just gynecologists, general practitioners and other healthcare practitioners as well. And there seems to be a great groundswell. I think that's really important. Anusch, I'm going to come to you. You get to give the final crystal ball gaze. Where do you see the future of endometriosis surgery?
My dream is actually fairly modest, and it sort of ties in with what Amani has said. I would really like to be in a not too far distant future where if a young woman or an older woman comes up and sees her GP and says, I've got period pain or I have pain, that they're not just ignored, but they're actually given the help that they deserve.
And, that's absolutely critical. We must listen to patients and the symptoms that they're presenting with. I want to thank everyone, all of our panel, both here in the Sydney studio and certainly in Brisbane and Melbourne too, for joining us today. We also want to thank our generous donors, because it's with their contributions that these events are actually possible, and we're able to provide you with much more information. And if you want to know anything more about endometriosis, donate to medical research, then please go to the Endometriosis Australia website at endometriosisaustralia.org. I'm going to say thank you very much. Thank you to all of our panellists across our 3 states, and we're going to see you next year. Thanks very much, team, and it's been great to have you.
Thank you.
Okay, see you later.